Welcome. I'm Giorgio Scagliotti. I'm professor of medical oncology at the University of Torino, and I would like to welcome you to the best of the day from ASCO. We are here in Chicago with Professor Pete Posmus from the University of Liverpool in UK. And first of all, I would like to ask you, Pete, what is your general impression about this meeting? Because during this program, we will focus mainly on thoracic malignancies, but I would like to get a sense from you about the meeting.
Yeah, no, what I find very impressive here now this year, this is a completely different meeting for the perspective of lung, certainly, because things that were moving during the last 2-3 years towards more personalized therapy, everything was detailed more and more according to pathways. What we see now is a completely shift of the approach. It's now going back to more generally applicable things like the immune system, which is affecting whether or not a patient is able to respond to treatment, whether the patient whether the tumor of the patient is more or less protected against the immune system of the person itself. And now these drugs, which are much more widely applicable, not only in patients probably with these pathways so far detailed, but also more in general with a much larger group of patients. So the perspectives for many more patients have changed during this meeting much more than the previous ones of the last, let's say, 3 to 5 years.
So the title of the meeting that you can see in every room is Illumination and Innovation. So can you comment on the concept of illumination and innovation?
Yeah, the illumination, I would translate that into we understand more and more of very detailed things happening in a tumor. Whereas we are now also trying to understand more general things that are happening around the cancer in a patient, which is not specifically related to the cancer as such. So how to say it? So what is the characteristics of the cancer? No, it's more the interaction between the body and the cancer, or the cancer with the body. So two ways. And that is changing now, because we are coming now at a level that we more or less understand how the normal defense of a person against a malignant thing happening in your body is not acting well, and how that can be overcome by adding drugs that interfere with these tumor protecting mechanisms.
Let me switch now gears to the field of thoracic malignancies, because now we can make easily comments on the 2 oral sessions that we had yesterday about localized disease, and today about metastatic lung cancer. This morning there were a lot of very interesting presentations, and the first set of presentations were looking to this third generation EGFR TKI, specifically active against the T790 mutation. There was a first presentation from Dr. Ramalingan looking to the potential use of AZ9291 in the frontline setting. Yes, last year we got a lot of information about the potential efficacy of this agent in second line. And the second abstract was on Clovis, on the Clovis agent, on the CO 1686, that now we have much more data, and we have especially interesting correlative science associated with the Tiger program that is investigating in different settings this drug. Can you make a couple of comments on that?
Yeah, let's start with the 2 drugs you mentioned. So the AZ9291 and the Clovis drug, the 1686. Both were last year presented as the drugs for a specific subgroup in the patients who were progressing while on a TKI, so on the first generation TKI, Alkene Ebit or gefitinib. And they were more or less presented to us as drugs that were active in a specific subgroup with a mutation in T790M. Now things are to some degree changing because the trial presented on the AZ9291 is a study in first-line patients, and these patients were not selected based on T790M. They were just selected because they have a mutation in EGFR. And what comes out now that the response rate is high and more or less comparable to the first generation TKI. So the question now comes, and that study is going to come, are these, for instance, this drug, the AZ9291, is that as good in first line as the first line TKIs are? And hopefully that answer will come soon in a randomized trial, which is at the state of being started now, so comparing this new drug against an older TKI.
Well, they presented data that in terms of progression-free survival, even in the context of an early phase study that is really promising, and obviously this is something is the background information for a phase 3 study.
Yeah, absolutely.
In the second presentation, there was a part of the presentation that was focused on the plasma DNA and in searching the EGFR sensitizing mutation and the T790 mutation in the plasma. Can you make a comment on that?
Yeah, this study is nice in that it demonstrates that being aware of a lot of reluctance among physicians to ask for a second biopsy in a patient to find out what is the resistance mechanism, it is in this study now shown that you can do it in a different way, just by looking in the blood, so the fluid biopsy, so to say, and see that if the mutation is there, it correlates very well with what is found in a tissue biopsy, and it also correlates with the response. And it even goes further because a number of patients in which it was not positive, despite that responded. So this might at least solve some of the problems for a lot of doctors as well as patients, that either the tumor is difficult to assess to get a new biopsy. So you have now an easier way to select your patients for this drug, if this drug is still a specific drug for the T790M, which is, if you look at the AZ9291, apparently not the case because it's active, as we said before, already in first line in a much larger group.
So we can say that also for those patients in which it's quite difficult to get tissue, probably in the near future, it's still early to say, but we can use plasma DNA to look for the T790 mutation, and this test can guide in some way the treatment, even if with both agents we found also responses in tumors that are completely negative. Yeah. For a matter of time, let me now move to the presentation on Alkene, that is a second generation Alkene inhibitor that has been presented by Dr. Wu. And again, the study demonstrates a couple of things that are quite relevant for this second generation Alkene inhibitors, and I would like to get your impression about this data.
This drug is a promising drug in this group of patients being progressive while treated with crizotinib, and it might even be a better drug than crizotinib, so it might end up in first line for these patients. But what I found very impressive as well, that those patients who had brain metastasis responded very well on this treatment as well, because that is an issue that is very difficult to deal with for patients as well as doctors. So I think this drug is really a promising thing, certainly in the group in which it was now tested as being effective after proven resistance against crizotinib, but it might very well end up earlier, and it might even go that far that it might be the drug to use if a patient presents with brain mets having the ALK mutation.
So we can summarize the presentation saying that Alkene Ebit, as others, second generation Alkene inhibitors, they have in common a better CNS penetration, so and consequently they are more active against brain metastasis. And secondly, they are active among crizotinib pretreated patients. That is another finding that could help our treatment algorithm in the future. And even in the discussion that Dr. Ajay made at the end of the session, he was making hypotheses about different treatment algorithms, keeping crizotinib front line and having these second generation Alkene inhibitors moving in the second line and third line setting. Another in the same session there was another couple of presentations of what we can call extremely rare mutation.
Yeah.
And there was a follow-up presentation of the last year. I would like to remember to everyone that last year Dr. Blanchard presented a preliminary series of patients with BRAF mutation and lung cancer. And he showed some relevant activity in terms of objective responses with some preliminary data on progression-free survival. This year, the same group is presenting another targeted therapy study that combined the BRAF mutations with the MEK inhibitors, specifically the two drugs were dabrafenib and trametinib. Can you make just a summary of this presentation or your opinion about these double targeted therapies in non-small cell lung cancer?
Yeah, this small subgroup of adenocarcinoma responsible for about 1.6 to 2% of the total population of adenocarcinoma, and of which around 1.6 have the V600E mutation, and that is apparently the group that is very well responding to dabrafenib. And now in the combination with the other drug, with the MEK inhibitor, trametinib, it's demonstrated that it has a much higher response rate without having so much more toxicity. So this seems to be a very interesting combination, active combination as well, for a kind of orphan disease within adenocarcinoma. So I think this combination will become the standard more or less for a very long time for this specific subgroup.
Yeah, we are not still in the situation of a kind of synthetic lethality as we saw in melanoma, but obviously the double combination is definitively superior to dabrafenib alone. Obviously, we need to monitor a little bit more, having more mature data about the toxicity, especially for what is the skin toxicity and the possibility to have squamous cell carcinoma. But again, this is something that probably the activity is overwhelming compared to the potential toxicity. Now, let me switch to yesterday afternoon when Dr. Suresh Sainan presented the final data about a large phase 3 study looking to the potential role of pemetrexed and cisplatin or cisplatin etoposide in combination with radiation therapy in the setting of locally advanced non-squamous non-small cell lung cancer. We saw many other presentations about the same study in previous meetings, but now we have the final results. I would like to remember to everyone that the study has been stopped based on an interim analysis that demonstrate the non-superiority of the combination of cisplatin pemetrexed versus cisplatin etoposide in this setting. But now we have the final set of data. There is no difference in overall survival. There is no difference in progression-free survival. What we can comment a little bit is about the toxicity profile of the two compounds.
So that's a small difference. And the nice thing in this study is that after, let's say, having a kind of standard treatment for more than 20 years now, someone has tried to change that treatment based on modern drugs like pemetrexed. Unfortunately, it failed in this situation, so it did not add up that this drug in this situation is better than the old regimen is. So at this stage, there's no difference. This is not going to change the practice.
Yeah, there is a difference, but there is the financial cost of the new combination. Then from a theoretical point of view, there are a lot of questions around the value of the control arm, because the control arm was using concurrent chemo and radiotherapy, followed by doublet combinations in the maintenance setting that are not really proved.
But that has probably not affected the outcome.
Yeah, it's true.
In both arms, not.
Another interesting study was the pharmacogenomic-driven study presented by the Spanish group using BRCA1 as a potential predictive factor. Let me say predictive in a positive way, because at the end of the study, BRCA1 was not able to identify any improvement, so the selection of the treatment through BRCA1 was not the right way to improve the efficacy of adjuvant chemotherapy. And I believe that the role of pharmacogenomics in the adjuvant setting is still an open question. Probably we need different study design, but in general, this study should be considered a negative study in terms of therapeutic outcomes.
I think this is more or less demonstrating that it is in this category of patients almost never one mechanism that is making the difference.
Yeah.
So there's so much more that it's unlikely that only if you target only on one difference between the tumors, it's probably not very promising approach.
Let me now finish with your preferred topic that you already discussed in a more general way at the beginning of this program. And I would like your comment on three different studies. The first one is the study presented by Dr. Luis Pazares, because it's the real latest information available about the checkmate study 057 of nivolumab versus docetaxel in the setting of non-squamous non-small cell lung cancer. We heard already before about the superiority of nivolumab in squamous cell carcinoma, and before this meeting we got already information through the web about this 3-month improvement in median survival time, and also a better performance of the immunotherapy in terms of 1 year and 2 year survival rates. But what is my interest today is to get your comment about the non-squamous study that is brand new in terms of data.
Yeah, for me this is let's say one of the first studies that demonstrates that a rather old regimen as docetaxel can now be improved by something else. But that does not mean that this is going to be the new standard, because there are so many more questions that need to be answered around this. And looking at the benefit is there, so there is definitely a better overall survival as well as progression-free survival. But is that sufficient from the perspective of what would be, let's say, the burden for the community as such to go for this as a new standard? And I did not agree with the comments, I think it was from Roy Herbst on it, that this would be the new standard. It might be the new standard in a very few centers around the world, but for the most of the people suffering from lung cancer, this at this stage of the development is going to be a no-go way, because it's simply going to be too expensive. So that's what the prospect is. And the problem still remains, if you have such an expensive drug, and you have to treat, let's say, 4 or 5 cases to have one who benefits, then the costs are in fact 5 times as high to get some benefit. So that is my most important comment. From the signal point of view, this is fantastic. From the patient care in the short term now, I have my doubts whether this will change the practice within the first 5 years.
Let me say that it's a fascinating story that
Absolutely.
needs to be tuned a little bit more.
We need to tune it up, and how can we improve it? So saying that we need 5 to treat to have 1 to benefit, it should be 1 patient selected who benefits, and no one selected who's not going to benefit. So that is the challenge now for both the company as well as for us as the scientists behind us.
So again, we are going back to the story of biomarkers, and from what we know, the PD-1 story as a biomarker is still in the air. We don't have any definitive solution, and even the responses, the objective responses have been seen in the PD-1 positive and the PD-1 negative, and we cannot agree on the fact that the PD-1 is valid for non-squamous, is non-valid, is not effective for squamous. So consequently, the story of biomarker probably needs to be investigated.
It's uncertain what kind of biomarker you're going to need for that. Should it be a tissue? Should it be a fluid biopsy? Or should it be something like a marker which can be detected by PET scanning of the tumor, just to see whether the tumor is lighting up, if the marker is going to the tumor? So these are all things that need to be developed. So you need to build in new technologies to improve your selection.
Okay, thank you so much for your comment. Thank you everyone for attending to this program. I'm Giorgio Scagliotti, talking from Chicago, from the American Society of Clinical Oncology.